Welcome to Conversations with Black Doctors, brought to you by the Austin Black Physicians Association, also known as ABPA. My name is Dr. Danielle Arnold. I'm a physician in Round Rock, Texas, and I'm going to serve as the moderator for our panel tonight. The mission of the Austin Black Physicians Association is to improve health disparities within our community and to inspire and nurture the next generation of Black doctors. If you're interested in learning more or collaborating with ABPA, please visit austinbpa.com to connect with us. That's austinbpa.com. The purpose of these webinars is to bring health information to our community from trusted voices in the Austin area. We want everyone in our community to have the knowledge to care for themselves in the best way possible. Please share this webinar widely. Today's topic is disparities in diagnosis and treatment of diabetes. This topic is important to the ABPA and the Black community because Black adults are 60% more likely than non-Hispanic white adults to have been diagnosed with diabetes by a doctor. Complications of diabetes hit Black communities harder, and we can make a difference when we know more. Joining us today are esteemed physicians in the community, two Austin area Black physicians who are experts on this topic. Dr. Paul Bristol and Dr. Jeffrey James. Thank you so much for joining us today.
It's my pleasure.
Thank you for having me.
Yeah. Do you guys briefly just introduce yourself to our guests?
My name is Paul Bristol, and I'm a family physician for the past 33 years. Originally, I'm from New York, graduated from Howard College of Medicine back in 1984 and came here to do my residency. And so basically for the majority of the years, I've done a traditional type medicine, which your traditional family practice. But my interests really are in diabetes, pre-diabetes, and cardiovascular diseases. And I've even been a principal investigator on some of the trials with these various diseases and the medications. And so over the past 2 years or so, I've slowed my practice down. I've gone from 2,700 or so to about 300. So now I am more of a Marcus Welby type doc. I've got 300 patients. I see a few a day, but also these patients have my phone number. They get in contact with me, and I'm doing more prevention now than I am doing the traditional that I've done before. The reason why is basically this, that's what I grew up with. My father had diabetes, died early at the age of 55 from a massive heart attack. So this is one of my pet peeves. And so being his son, I have a lot of his same genetics. And so this has always piqued me. And so that's something I try to teach and instill in my folks. So, Jeff?
Yeah, that's pretty impressive. My name is Dr. Jeffrey James. I'm a specialist in internal medicine. The location of my practice is East Austin, the place where I was born and raised. I went to Texas Southern University, a historical Black college, at a time in which the Black Power movement was evolving, which eventually blended in with the Civil Rights movement. So I was highly influenced by that, particularly given where I was studying in Houston, Texas. So I majored in pharmacy, and as you can imagine, that entails a lot of basic science, But looking forward or ahead, I did not see myself, after the end of 5 or 6 years of study, practicing pharmacy. The academics were very challenging and interesting, but the actual practices was pretty mundane. At that time, we would formulate drugs, but for the most part, you're standing up in a store for 8 or 12 hours counting pills. And I just couldn't see myself doing that forever. I considered doing graduate school in pharmacology, but then I would have to be a researcher. And at that time, I was beginning to think that I wanted to involve myself with people. And a lot of that was motivated by my involvement in the movement, going all around the United States, dealing with certain personalities that were activists. And so I decided that if I could blend the basic sciences with and pair it with a social commitment to be totally committed with undying love and devotion to uplifting and improving the welfare of Black people, that became my commitment. And that's why I came back home after studying at University of California, San Diego, studying at in Santa Barbara, studying with the United States Public Health Service Corps, all kinds of stuff. I always intended to come back and give back to those who gave to me. So that's why I'm here.
Yeah, thanks again.
Very
to
nice.
both of you. So we're going to jump right in. We hear that people have diabetes and that they have to take medicine or check their blood sugar. We just start with the basics. What exactly is diabetes and how do some people get it?
Yeah, interesting, isn't it? Diabetes basically is an elevation in blood sugar, as we say. The way I like to explain it, you have a car, and in order for that car to go, you got to put gas in it. It needs fuel. Well, basically, with the human body needs fuel. That's glucose. So basically, everything you eat eventually breaks down into glucose. And it's glucose that goes throughout the body, through the circulatory system, that feeds those cells and gives those cells energy. Now, in order to get the glucose that we eat, and it's produced into these cells themselves, and you got to remember, you've got close to 60,000 miles worth of blood vessels throughout your entire body. In order to get those cells to have glucose, you need insulin. Insulin is produced by the pancreas. So whenever you eat, the pancreas produces insulin throughout the day that puts that sugar in the cells so that they're getting their energy. But sometimes insulin production isn't as optimal. So with type 1 diabetes, those individuals have what they call an autoimmune disorder. The actual immune system attacks the pancreas. They don't produce insulin at all. Those are what you call your brittle or your type 1. Then you've got to your type 2, which they produce insulin, but they may not produce enough insulin, or they are resistant to their insulin. So in either case, your sugars go up, and your sugars have to be in a certain level. And so the definition of diabetes is any blood sugar greater than 126, or hemoglobin A1C, which is an average of the blood sugars over 3 months, greater than 6.5, or a glucose tolerance test where you drink the sugary stuff and your sugars go up over 200. Well, when those sugars are elevated, they cause havoc on the body. And that's where you start. You have both small vessel disease and large vessel disease. And so we're going to get into prediabetes and insulin resistance a little bit further down the line. But that's basically, in a nutshell, what it is. It's elevated blood sugars, which cause havoc on the body.
So it's sort of thinking about a problem with insulin, and insulin's sort of the gatekeeper to get that energy into the cells. So there's something
That's
wrong
exactly
with the
right.
gatekeeper. Okay. Yeah. So what about risk factors, or what kind of things put you at risk for diabetes, Dr. James?
Oh, the primary, the criteria for establishing risk in pre-diabetics as well as diabetics depends on being obese, number one. And if you're obese and you have one or more other risk factors that put you at risk for developing diabetes, and those other factors would be family history, having a first degree relative with diabetes, mother, father, brothers, sisters. Of course, ethnicity or race is a high risk factor, being African American, being Latino, Hispanic, Native American, Asian American, Pacific Islander, places them at unfair risk or excessive risk or extra risk for diabetes, development of diabetes. If you have a history of cardiovascular disease, you've had a heart attack, or if you had congestive heart failure, that is a risk factor. If you have hypertension already diagnosed, or if you have a blood pressure greater than 140/90, then that is a risk factor for diabetes. And then if you look at a cholesterol profile or lipid profile, it has various components. There is a good cholesterol called high density lipoprotein, HDL. If it's below normal, and if your triglycerides, which are a form of fat, are above normal, both of those things which can predispose to diabetes. And plus they become a component of a disease set that we call a metabolic syndrome as part of that. If you have women in particular with polycystic ovary syndrome or ovarian syndrome, that's caused, it's a triad, or there's 3 manifestations of that. If you have an ovary with cysts on it, then it would interfere with getting pregnant. Number 2 is you would have amenorrhea, prolonged or extended menstrual cycles, okay, because there's a hormonal imbalance. Number 3, you could get hirsutism, which is facial hair. And those 3 components, a woman with polycystic ovarian syndrome make them at high risk, have a high prevalence of diabetes. And finally, people who have sedentary lifestyles, just sitting around, like right now, we're all sheltered in, getting fat. I was trying to stay away from coronavirus. Well, obesity in particular, it leads to insulin resistance that Paul spoke about. It leads to the concept that you talked about. I like to say that the hinge on the door becomes stuck. And so you have your cell, every organ in your body is made up of cells. Okay, it's like a room. Like I'm in this room in my office, and I have a door, and that door leads to a hallway. My patients go up and down that hallway. If I don't open this door, they can't come in, we can't interact. So I need fuel inside that cell. I need glucose and I need oxygen. If that door, the hinges are rusted and they won't open, then people are knocking on the door, beating on the door, the insulin is banging on the door. So you get more insulin. You say, well, they're not listening to 2 insulins. They're not listening to me producing 5 units of insulin every hour. So let me produce 20, let me produce 100, let me produce 1,000. Well, after a while, if you have a car and it has 15 gallons of gas and you start using it up and get to empty, guess what? You can't run, you can't move. So these are very simple kind of scenarios that I try to share with my patients so they can have a visual image of what's going on with their body. So when I give insulin, that puts more components to break that door down, okay? If I change my lifestyle, the way I look, the way I live, it also imparts more efficiency in that door opening, and we're getting attain normal glycemia, which Paul mentioned. So the risk factors are the ones that I mentioned, and there's some other risk factors that I'll talk about later, which are social determinants of health, in terms of the economy, environment, political and social conditions of these people, of our people who are faced with developing diabetes.
Yeah, so what do disparities or differences in the Black community look like when it comes to diagnosing and treating diabetes? And why does that matter?
Well, it's important that you have access to health care. One thing that you see, and especially in the African-American population, is trust. You have individuals that want to go to the doc, but if they can't identify with them, they don't develop that connection or that trust. They don't trust, then basically, then access to health care gets impaired. And so it's important, as far as barriers, to find a physician that you trust and that you can connect with, that you can listen to. When you have that, you build a relationship over the years. And then the most important thing as docs, what we are is basically we are teachers. Our job is to teach and get the science that we know and help our patients, our loved ones, to understand why they need to lose that weight, why they need to exercise, what this particular medication is doing. And it takes time. But in medicine today, time, every 5-10 minutes, you're running in and out of the door. You really don't get that time to connect. And that's what's important. And so when we look at barriers, many patients are given prescriptions, but they don't know why they're taking them. And if a patient doesn't know why they're taking a medication, guess what? They're not going to take it. And so that's why it's important that we break down those barricades. The key thing is education. Individuals need to understand that. Everybody thinks that once you get diabetes, I just got diabetes. No, you didn't just get diabetes. What you failed to realize is it took about 10 to 15 years before you even got to the pre-diabetic state to the diabetic state. It takes that time. And so the insulin resistance becomes pre-diabetes, which becomes diabetes. The studies already show that. And by the time you're a diabetic, only 10 to 15% of your pancreas is working. So the key thing is the barriers is catching these individuals early enough so that you can make some of those changes in their life. Proper exercise, proper dieting, getting things, those high density carbs, and learning what these things do. One of the worst things in our communities is the juice, the fruit juices, the sodas. That started back in the 70s. And what did you see once they started changing the glucose into fructose into corn syrup? You saw the obesity rates go right up. And that's exactly what we see today. So when you talk about the barriers, you have to get proper care, physician access. You need to learn more about the disease. 3, you need to better foods, quality foods. Now, when you go in our communities, do you see that? Not as well in some other communities. You really don't. But things like this have to change. But we have to get on a basic level with our patients, and we have to teach them, and we have to nurse them along, make them when you make them understand what's going on, they're better to make those changes. And so those are some of the barriers that I see. Jeff?
I'd just like to echo what Daniel started out saying for his incidents. African Americans have 60% more likely to develop diabetes than white people, number one. So that of our population, about 13% have diabetes, as opposed to 8% of patients among white people. As far as barriers, I'll just add from a different twist. There are multiple barriers that cause or interfere with access to healthcare delivery in this country. And insurance is a major one. Having or not having insurance. Well, how do you get insurance? More than likely you have to work for a good company that offers it. And a lot of times we're working, particularly in this state, for companies, small businesses that can't afford to give insurance. If you look at Texas with 5 million people, we have an uninsured rate of 18%. So if you rate us, compare that with the rest of the country, we're number 51st. And if you look at children alone in the whole country, 20% of all children in Texas are uninsured versus the whole United States. 20% of all uninsured children in the United States are in Texas. So that's fairly significant.
Yeah, we have a lot of work to do here.
Yeah, insurance is a huge barrier. Second is transportation. You know, if you don't have a car, can't afford a car, then you may or may not be able to get to the clinic or the hospital that's not in your neighborhood. So that's a barrier. Third would be childcare. Who's going to keep the children while you're going across town, catching a bus or hiking or whatever you do, hitchhiking? That's a barrier. And then residential housing itself, or segregated housing, is a barrier. Where do we live? We live in segregated housing. Where are the healthcare centers? They're not in segregated housing. And you mentioned about food deserts and food restrictions that are apparent in our neighborhood, how we are forced to utilize sugary drinks. The average store in the neighborhood is a mom and pop store, and it has no grains, whole grains, has no fruit. It got 40 ounces, lottery tickets, and sugary drinks. Okay, all that predisposed to disease, and also it's a barrier for getting well. Now, you asked about mistrust. Where's the mistrust in the medical system? Why don't we trust when we go to the doctor? Why are we suspicious that they're going to do something bad to us as opposed to do something good? What is
because they have.
Yes. Okay, that brings up a good point. So that the Tuskegee syphilis experiment which started in 1932, okay, where they took, this is in Tuskegee, Alabama. The Public Health Service collaborated with Tuskegee Institute in Alabama. And they formed a study, a clinical trial, where they had 600 men, 400 of whom had syphilis. Now, syphilis is a bacterial disease that can infiltrate your brain and your heart. It can cause dementia, it can cause memory loss, which is memory loss. It can cause depression, mental illness, and it also can kill you. So they took these people and said, well, we'll give you free food, free meals, we'll give you free exams, and we'll give you free burial insurance. But the men did not know that they were not getting treatment for the syphilis. Yeah. So in 1932, we really didn't have treatment, but the fact that they were going to do the Cronian studies and have these men with syphilis and watch them, initially they had planned to watch them for 4 to 8 years, but they ended up watching them for 40 years. They only stopped the study because of moral condemnation of what they were doing. In 1947, we discovered penicillin. That's the treatment for syphilis. Now, one of those men, black men, got a penicillin. So they just watched them decay, forming large gomas, big knots all over their faces and bodies, skin turning colors and stuff. Men walking with imbalance, falling down, and ultimately dying from either nerve disease or heart disease because of this demon. And yet they just stood by and watched till it was interrupted. So that experience didn't go over our head. That experience, even those people don't know about all the details. They know that something was afoul there. And so if you look at and we're not well represented in legitimate experiments, in legitimate clinical trials. If you look at cardiology, probably we're representing less than 4% of all cardiology trials if you look at it historically, okay? So if you devise or do an experiment or devise a drug to treat a certain condition based on a certain characteristic and you're not represented, that means that drug may or may not help you, but we just give it to you anyway, okay? So it's suspicion. And I'll speak a little bit more on that on some questions that are gonna come forward.
And let me just add to that, I did plenty of those trials, and the hardest thing we had to do was recruiting African-American into these trials.
Because of their lack of trust.
Their lack of trust. And so, and even the thing about it too, is very few African-American doctors do these trials. And so when you've got a few African-American MDs or docs doing trials, you've got the trust of the community. And then basically a lot of these medications are coming to the fore and they haven't been tested on all the populations. So we get left out. Yeah. So, you know, he's right on the button on that. And that Tuskegee trial, you know, Clinton, and I mean, they had to recognize that. And actually, when you look at the principal investigators and you go through their course and have to take the exam, that is on the exam. That's where all your ethics and things came out of that trial, because that was absolutely horrible what they did to those men back there.
Yeah, so we don't have to look even back that far in history to see that Black people get different treatment and many times less than standard treatment in healthcare. So what are the things that you guys are doing, or what can we do as patients, as family members of people who have diabetes to get around that? I mean, what are some of the ways that we fight that?
We have to speak up. We have to speak up, and we have to, as families. One thing I find out when I see a lot of my individuals come in, I ask them, do you know your family history? Who has the diabetes? Who has the high blood pressure? Well, a lot of them don't know. And that's because it's something that we just don't discuss among ourselves. Because a lot of times you'll ask, okay, Dad, what are you taking those pills for? Boy, what you want to know for? Mom, you need to, we have to get past that. Our communities, fathers, sons, daughters, we all need to know what's going on in our families. And then we need to take that information, and when we go to our physicians, we need to tell them, Listen, my dad had diabetes, mama had diabetes, my brother's got blood pressure, this and that. We need to do that, but we need to speak up. And unfortunately, you know, when I see some individuals come back from the emergency rooms after they've been treated for something, I look at it and I say, God, they knew better. Why didn't they do? Now, if it was another patient, they would have done this, and this. This, all they did with that doesn't make sense. So unfortunately, even in the emergency rooms, there's disparities, and we see it, and it's a shame. But that has to change. We have to speak up. We need more African American docs.
Okay, well, that's certainly the mission of ABPA. So we want to do that work. Speaking of speaking up and talking to our family members, how do you know if you or if you have a loved one has diabetes? Like, how would you know?
So basically, when you talk about signs and symptoms, you got your 3 Ps: polyphagia, which you eat a lot, and polyphagia, dipsia, and where you drink
Urea.
a lot.
Polyuria.
Polyuria, where you pee a lot. So bottom line, those are your big things that most people you will see. But then also other things is weight loss, abnormal weight loss. You'll see that. Sometimes dry mouth. Sometimes you'll see sores that don't heal, things like that. Those are things that you see. So it's different. So in your brittle type 1s, you see those things, your polydipsia, polyphagia, polyuria. But you will also see other things that go on with that. And sometimes their sugars can get so high, they'll start having problems breathing. Now, type 2, it's a little subtle. So type 2, they may have erectile difficulties. They may have sores that don't heal. They may have rashes on the skin, such as yeast infections, or men in the groin area or female in the groin areas. There may be a sudden increase in weight where they become more insulin resistant and they'll have these symptoms. Those are some of the symptoms that you see. Now, some of them, the last 2 that I received in my practice, their sugars were over 900. So with that in mind, they went to the hospitals, they got treated, and then they came back. And of course, we took it from there. But their biggest thing is they were thirsty all the time, they were urinating all the time, and they were hungry all the time. When you get sugars like that, yes. So, I mean, so it's just knowing your body and being in tune to your body. And then also getting your regular checkups. And Jeff hit it right on the button. You have to have access to health care. You have to be able to get to the doc. So if you got to get to these clinics, these places, and then also you've got to know your family history. Do you have a history of gestational diabetes? Well, if you had diabetes when you were pregnant, there's a good chance you'll be a diabetic later on down the line. You need to know that. We need to educate these mothers when they have babies. You are a gestational diabetic. You are preeclamptic. You need to watch out for hypertension. You need to watch out for diabetes, especially if you have a family history. There's an old saying, fruit does not fall too far from the tree. Mm-hmm. And everyone wants to be in denial. I ain't getting that. Listen, you're who you are. And you have to understand that. And so, you know, I've got folks in their 20s and 30s with impaired glucose tolerance tests. When I see an 18 or a 19-year-old with acanthosis nigricans, that's where you look at the back of the neck and you see it looks dirty, that they haven't washed themselves. That's insulin resistance. See, right then and there, you need to start being proactive. The youngest one I had was, she was 17 and her sugar did a 2-hour glucose tolerance test. Her sugar went up to 240.
Yeah.
She's not obese.
And one of the things that's really, you know, you mentioned people sort of saying, well, that ain't me. And the great thing is that if we know our family history and we do some work beforehand, it doesn't have to be us, right? That's a great thing. So
diabetes is preventative.
Yeah.
You can prevent it if you started early. Jeff?
Yeah, I think education is a key, but the question is, where do you start this education? You have to start it in grade school, pretty much. You know, just as they're trying to promote physical education, they should promote health education as well. You know, you have certain kids who won't eat anything green, red, or yellow. okay? When I grew up and the way I grew up, if I got preoccupied with playing and it was late in the evening, and if somebody had a watch, if somebody said, well, it's after 6, I just stayed out playing because I know if I got home, there wasn't gonna be nothing on the plate.
That's right.
If you late, you miss out. I ain't say, Mom, I don't want to eat it because it's green. I'm not gonna eat it because it's yellow. Mom, I'm not gonna eat it because it's red. Mom, where's the food? Okay. So we've gone from, and we have, as I mentioned, food deserts, and people, if you can teach the kids early where it becomes a part of them. For example, I have 3 children, and my middle child, well, we never kept salt on the table, all right, for reasons. Salt predisposed to hypertension, particularly in Black people, for various reasons. Not the topic today, but we could talk about that. But when my daughter became 13 or 14, and she became rebellious, we went out, had this great dinner to this 5-star restaurant. And the first thing she did was grab the salt shaker and shake it on the food. And I said absolutely nothing to her. And everybody was eating and enjoying their food, but you could just look at the corner of my eye, I could see her face because she wasn't used to eating salt.
Oh, wow.
Trying to make a statement. So you got to make statements early and with your children in terms of feeding them healthy diets and also getting them engaged in exercise.
Yeah.
It becomes a part of them. If you're out taking walks with your children and your dog, then after a while they think that this is part of what you have to do. But it's education is a primary way. If you can have an outside observer say, there's something wrong with you. You've gone to the bathroom 10 times this hour, okay? You've drank a half a gallon of water this hour. There's something wrong with you. Didn't your parents have diabetes? Did somebody have diabetes? As Paul said, he admitted somebody or sent somebody to the hospital with a sugar of 900. First, the sugar shouldn't be over 100, okay, unless you just ate. There are a lot of people who will present for the first time with diabetic ketoacidosis that they didn't have enough functioning fuel to provide the machinery of their body to go on. So poisons or lactic acid build up and you pass out in a coma. And sure enough, your sugar will probably be 1,000, 1,200, 800. You say, I never knew I had diabetes. As Paul said, it takes at least 10 years to develop the symptoms. Once your pancreas is devoid of 50% of its insulin, that's when you start seeing hypoglycemia. But it might be very subtle. You say, well, I've been going to this doctor for 7 years and then I just got diabetes. He didn't follow me well. No, your body compensated for it up until that point. Instead of producing 5 units of insulin per hour, started producing 10, 20, 50 units until it ran out of gas. They had no more insulin. It was trying to compensate. And when it ran out of gas and couldn't compensate, that's when you had manifestation of diabetes. And I like to make one other point that we missed. He talked about early diagnosis. What is the natural history of the disease? What does it do to you? And how does it do it? Well, the natural history of the disease is that this excess sugar in your circulation is called hyperglycemia. It's caustic to the lining of your arteries. It's caustic, the lining of your arteries. All oxygen and nutrients have to travel by way of circulation, and that's made up a network of arteries, okay? There's something about insulin that affects the endothelium or the lining of that artery to where it gets thicker and thicker and thicker and thicker. It's called atherogenesis. And that occurs throughout your body. Every organ in your body, your eyes, your ears, your nose, it needs oxygen and nutrients or your nose will fall off, okay? So who delivers that? You have to have a patent circulatory system. Right now it's 5:40 in Austin, Texas. And I'm not leaving my office for another couple of hours because I know if I get on that freeway, I'm not going nowhere. The freeway is there to deliver me, but it's crowded with trucks and stuff. Those trucks can't deliver their produce because they're not going anywhere. So if your truck can't deliver their produce or product, if your red blood cell, which is coated with sugar like a donut and coated with oxygen. If you can't deliver that product down line, then you're going to have what's called macrovascular disease or macrovascular disease. Micro means small and macro means big. Micro would be your eyes, your feet, and certain parts of your kidney. If you have hardening of the arteries and it can't supply nutrients to those things, then you might go blind or you might lose your feet. The large vessels that supply your brain and your heart, once they become occluded, that's a heart attack. Once your brain becomes occluded, that's a stroke. Simple. We didn't keep the highway open. So there's something about increased by hyperglycemia itself and high insulin levels itself that seems to be cytotoxic to the endothelium, make it get thicker, and you end up with all these diseases.
Yeah.
Yeah, I think you guys, I love the analogy of the gatekeepers not working. And then now we've got highways that don't work. They can't get the energy to these organs. And I mean, I want my eyes to work. I want my feet to work, so that's, and I want my heart to keep ticking. So that's the end result there.
When you're Marcus Welby, you have to be able to place things on a level in which your audience can understand. Okay.
That's right.
There has to be a duality. If I go and give a lecture to some doctors, I'm going to raise it very high on a high level, make it very academic. But like, we're hopeful that the regular public, in particular some children, will watch this webinar. So you have to bring it down into a level in which they can understand.
That's
You
right.
have to appeal to your audience. We're going to talk about language barriers and other barriers, but that's one of the, I think, the standouts for having people of color providing medicine. If you've had the Black experience and you accept you had the Black experience, then become Clarence Thomas or Ben Carson, then, yeah, I'm throwing darts, but then you have a responsibility, not only to stay current on evidence-based medicine, but find out how you can translate that. Unless they understand it, it's not doing them any good, okay? If I tell you that I want you to adhere to this diet, a particular American Diabetic Association diet, you say, okay, I'm gonna eliminate carbohydrates, I'm gonna watch my fat intake, and I'm gonna eat adequate protein, but I go to Luby's, I'm gonna order a diet soda. See everybody, a diet soda. But I'm gonna mix that with a chocolate mousse. They're not balancing.
Yeah. And he hit it right on the button there. And the number one killer in America is what? Cardiovascular disease, heart attacks. And the key thing is, so basically when you look at it, first time I get a person that comes in, because I do a lot of cardiovascular disease. When they've had a heart attack, the first question you ask them, are they diabetic? Why? Because basically, as he brought out, it's so caustic to the endothelium. It's almost like glass running through the endothelium, scarring them, opening those so the cholesterol can get in. But you'll find that the person's first heart attack is with an A1C of 5.8. They're in a pre-diabetic range. They're not even a diabetic, which is 6.5. First heart attack, average is 5.8.
Yeah, so we're seeing complications, major
That's
complications
right.
of diabetes before we even have the formal diagnosis.
Yeah. I've just had 2 close friends die from massive heart attacks.
Yeah. We're sorry to hear that, Dr. Bristol.
Young.
Yeah.
And there's no need for that. What we know, and as Jeff brought out, we are teachers. Medicine is the art of teaching, and we never need to lose that art of teaching.
Yeah. I'm sure that there's so many people watching who wish they could have either one of you as their doctors, but we can't all go to Dr. James or Dr. Bristol. So if, there are people out there who are seeing doctors, they're doing their part, and they may be worried that their white doctor or non-Black doctor of any race doesn't really understand what's different about diabetes in Black people. So how can they speak up for themselves? How can they advocate for themselves? Dr. James, you want to talk about a little bit?
Speaking of the provider himself or herself, I think one of the key to interaction with people of color is number one, to listen. To listen. When they come in, you make eye contact and you ask, what problem are you having today? Is there something you're concerned about? Is there any problem? And then you have them spill out about the husband didn't come home, the teenage kid is smoking dope, the adolescent girl is wearing her dress up to her neck, all this stuff. Or they suffering from spousal violence, and it goes on and on and on. And after you kind of listen to that and you kind of direct them to what the medical problem is, but you kind of listen, you're listening. And you listen with, you gain trust through empathy. You can tell when somebody really is listening or they care about what you're saying. And you can tell when they don't. So there are a lot of interferences with getting to that point. And one of the things you have to take into consideration is the cultural state, the cultural beliefs of the people that you're dealing with, their preferences, their literacy, their language. If they're speaking in Ebonics, you should be able to interpret that, okay? And not put down that you're just dumb and not white. And then a lot of providers will bring into the arena explicit bias and racism that they're not even aware of. For example, you can have two women with metastatic breast cancer. That means cancer is spread all through their body, spread into their bones. If you ever have a toothache, that's what cancer in your bone is like. And the white woman has it and the black woman has it. And the white woman, they give morphine to relieve the pain and establish palliation. And the white woman, black woman, they give them something less because y'all tough. You've been out in that cotton patch, you got tough skin, tough bones. Plus, we don't want to turn you into a drug addict. Hello, there's a good chance you might not live long. You're concerned about turning me into a drug addict rather than palliate. And it happens in the emergency room. It happens outside the emergency room. We're always drug seekers, okay? Based on your injuries. They'll give you a 3-day supply of analgesics, pain relieving medicines. Or they may give the other person 7 to 10 day supply, okay? May not even be conscious that they're doing that stuff. But that's a major difference. And that's another reason why I agree with Paul about calling for the need for increasing the workforce with people of color, Black, Hispanic, Asian, Indian, so that we can give patients access, give patients the ability to go to the doctor knowing that he has his well-being in mind. I used to refer patients to subspecialists a million years ago, and they would come back and say, he never touched me.
Yeah.
Okay, now when I started this practice 100 years ago, I've been practicing a little bit longer than Paul. I'm not gonna tell you how long.
I'll tell you.
When I was teaching at Brackenridge, and he was one of the students. He wasn't my student, but that just tell you how old I am. When I was attending physician down there for several years, he and Patsy Jones. At any rate, so what we have to do is you just have to increase the workforce. I don't think that you can successfully debunk racism, whether it's conscious or subconscious. I don't know what the answer is. That's what we're grappling with right now, during this Black Lives Matter movement, right? And you have some people who are sympathetic right now, but I truly expect a backlash, okay? There's gonna be some people who say, oh, you guys got enough. You've had enough advancements. You've been on CNN for a month, okay? They had Paul and Jeff give a talk along with Danielle for this month, you know. And let's go back to Make America Great Again, all right?
Yeah.
I can see that happening, but it has to come from us. You know, churches have to get together, whatever organized groups that have influence on our people, you know, then we need to get them to take the lead and not just sitting back in the pulpit doing what they do, okay? You have to establish, you got capable people who are members of church, Paul, myself, or whatever, and you'd be surprised at how little they use your expertise. Even though we're faced with, you know, strict time schedule. But it has to start early. We have to get more people of color into the physician force. And I don't know what we're going to do about changing the attitudes of those providers. Yeah. But I was going to tell you that when I was seeing patients to the subspecialty, when I first started practice, little old ladies would come in and they seen this young guy, okay? And I was a little young and looking young. And so I would take a history, be empathetic, and this little old lady, after I heard her story and heard her problems that were going on socially, I said, well, I'm going to step out. I want you to put this gown on, take off all your clothes, and put this gown on. And I say, mister, please, ain't no man seen my body except my husband, and he been dead 40 years. So I say, well, listen, you paid me a copay, I'm going to take your money. I got to do my work. Now I'm going to step out here, you take them clothes off, and you put those clothes, put this gown on. So they be grumbling and mad. I come back, they got them on, and they all like this. After a while, they loosen up, okay? And they expect to be touched, to be examined. Yeah. I send them to another white subspecialist for opinion or some more direction or management. They'll go in, sit down, 5 minutes, they get up and walk out. I say, wait a minute. My doctor make me put on a gown. My Dr. James. So what established was a reputation. If I referred you to somebody for an opinion, I expect for you to take care of that patient.
Yeah.
When that patient came in and said, whose patient is Dr. Okay, it's Dr. James' patient. I'm gonna do everything right, because otherwise I'm gonna hear from it.
Yeah.
No, I agree. Just one thing on that. When my patients come back from a specialist, my first question, how'd they treat you? If they don't treat my folks right, they ain't going back. I only send my folks to folks that I know that will sit down and talk to you and touch you. And that's the key. And that another thing he brought out a nice point, look at your body mass index. A lot of times I get new patients that will come in there and they'll say, man, I went to a doc and they say, this man's a big football player, 6'4", 250, but muscle. They say, I need to get down to 180. Man, you will never be 180. You are muscle, you are built, you can forget, but that's what you hear. And so we are different, our bodies are a little bit, but you know what? That's where connecting more African-American docs, patients, they need to learn. And so basically we you know, these things that we're talking about, diabetes, and they affect us. So we have to know about it.
I think, you know, you're right about getting more Black physicians in medicine, taking advantage of community resources. You know, there may be some other things we can do, you know, when we have an interaction with a physician, whether they're white or, you know, whether they're Black, any race, and they don't provide that education and that connection, we say, hey, we need another appointment so that I can learn more about this because I don't understand, right? So kind of speaking up for yourself. Those are some of the things I know that, you know, we can do, and thinking about other resources like a diabetes educator. That's something people may or may not have access to, but they can take advantage of a person who's specially trained just to teach them about diabetes, because there's a lot to learn. So, and we've covered a ton of stuff. We actually are going to have to wrap up here. I know you guys.
Oh, you know, this was fun.
I'm just getting started.
You guys,
this was a blast.
Okay, so we're gonna do just one last question. If there's just one thing that you wish the Black community knew about diabetes, and we'll quickly, what would that be?
You want to go ahead first, Jeff?
Just be aware, keep your eyes open, and for his education, you should utilize American Diabetic Association. I do. I mean, I used to, when I would give talks in churches to groups on diabetes, I have pharmaceutical. This is the way I did it. I'll go to the preacher. I say, well, I need about 50 year parishioners. We're going to give a diabetic education course, and we're going to feed them. So I make certain the pharmacy is going to be at noon. So people come all dressed up on Saturday because they're going to eat. They bring them some good food. But at the same time, you had these educators that would pair off and show them how to do insulin, how to check their feed, and talk about eye checks and all that stuff. And then they would get free supplies, free insulin and all that stuff. Well, that would go along very well, and then some preacher decided he don't want that in his church no more. So that went that. We would have carnivals where we'd have all the home health organizations, all the health educational organizations funded by the city of Austin or independent. We'd have them come. You'd have 100 booths. We have all kinds of stuff. Didn't work. I mean, from every angle you can think about, we've done that. But what I say, just keep an open mind. I mean, it's real when you look at the consequence of uncontrolled diabetes, when you look at the fact that non-Hispanic whites or African Americans are 3.5 times, have 3.5 times the likelihood of developing renal failure. That means you're on dialysis 3 days a week for 4 hours a day. We have 2.3 times the likelihood of having lower extremity amputations. You can't run 100 on one leg, they'll cut off your toes. They start off the toes and go right up the leg. And then of course, we're twice as likely to die from diabetes. How permanent is that? Okay, so this is serious, very, very serious. And to a large degree, it can be treated. We have a modality, we have some armamentarium, some good drugs that can affect the cardiovascular end organ damage. One in particular you see advertised as Jardiance. It costs $100 billion unless you know how to get it for nothing. But it's a sodium glucose pump transport. You don't have to worry about that. But at any rate, so what it does is it lowers your blood sugar, but it has what's called a pleiotropic effect. It has an effect that we're not sure about. At the same time, it prevents your developing congestive heart failure. So it does other things, does things other than just lower your blood sugar. So those things are available because congestive heart failure is a major cause of death in Black people. 25% will die within the first year from congestive heart failure, and 50% will die within the first 50 years. And all of that is treatable and reversible. There's a study quickly called BiDeal, in which they looked at some old drugs that nobody wanted to use. They use it in people with congestive heart failure, 1,200 people with Black people with congestive heart failure. There's never been a solely Black study done ever that was published in America. They took these people and they were to show that with these cheap drugs, they could decrease hospitalizations by 50%, increase longevity by 50%, and increase well-being. Patients who were confined to bed couldn't go to a restroom, could get up and go to a restroom. Yeah. That functionality. And guess what? That drug disappeared because the first question they asked is, how do you know it's applicable, it's effective on Black people? How do you know those Black people were Black? Did you do a DNA test on those people who were enrolled in the program? Because there'd never been an all-inclusive Black study done before. So the FDA released the drug with the understanding that, with the attachment that you will do the same drug, you will do some same tests with white people with these two cheap drugs. Okay. Any rate,
Dr. James, that was a lot more than one thing. So
okay, sorry.
I'll be nice. I'll
this
cut
is
it
getting
down.
Good.
We love your passion. That's why we'll have to have you back.
All right.
Diabetes, they are preventable. 99.9% of this stuff is prevention. And knowledge is power. If you're going to win the war, you need to know the enemy. Education is the key. Exercise, 22 minutes, studies show will do a wonderful, just do something. And so these diseases, they don't have to affect the African-American population. That does. There are things that can be done. Knowledge is powerful.
Yeah. Thank you so much, Dr. Bristol and Dr. James. We're so grateful for your time and your expertise. Thanks to the audience for listening in wherever you are. ABPA wants to continue its mission to improve health disparities within our community and inspire and nurture the next generation of Black doctors, because we need them. Please visit our website, austinbpa.com, if you or your organization wants to partner with us. Again, that's austinbpa.com.